you all for today's webinar, which is organized by Department of PMR SVNIRTAR in association with Odisha Association of PMR and under the aegis of IAPMR. First of all, I wish you all a happy Puja festive, and our participants are also very few. Because of that reason, most of the people are enjoying their puja. So still, since our commitment, we'll at least do one webinar in a month. So this time it's my turn to present a something uncommon topic, which is less discussed whenever we discuss about the CP. Most of the times we are very much concentrating about the ROM, muscle power, voluntary control, POP angle, all these things. But sometimes behind that, this story of all this evaluation procedure is a dysfunction in the liver arm. So that we are going to we are going to discuss today. It is related to our normal day-to-day evaluation, but hardly we think about this, that what is the reason behind this liver arm dysfunction. So without wasting time, I think I should start the presentation on liver arm dysfunction and CP. Okay, so friends, you if you see this picture, this is a typical picture we used to see. We enjoy these things in the different parks when we play with our kids. If you see that in a park, you will have a seesaw where one child is sitting one on one end and the other is sitting on the other end. They used to play with this. With this picture, you can see that even with a small tortoise is balancing the body weight of a child, though might be the body weight of the child is more than 10-20 times of the tortoise, but still if you see this picture, this is in balance position. This is the beauty of a liver arm. Many things in mechanical way or in our life, in our body, many things are happening because of the liver arm, and we are enjoying the advantage of the liver arm in our body, so that the force requirement is very much less. As you see in this case, the force requirement very much less to just lift up a 10 or 20 times body weight of another object. So this is basically liver arm. If you see this picture, this is take a liver arm. This is a fulcrum around which this arm is moving, and this is a weight. This one weight we can call it is a force end, another is an a resistant end. So our whole body of different joints of our body works in this mechanism. So, what is that lever? A lever is a rigid segment that rotates around a fulcrum. Same picture, it's a rigid segment that rotates around a fulcrum. A lever system exists when two forces are applied to a lever in a way that it produces a torque. So, whatever movements we are getting in our body around a joint, that's a torque, and that's because of the two forces acting to providing a movement, that's called the moment. So this moment is produced by a effort force. In this case, if you see that there is a weight over here and another person trying to lift up this weight. So this he is using his body power to lift up the body. That's the effort. This is the effort. This one end is means it is effort. Other end is the force or resistance force, and this is the fulcrum. And this whole lever is divided into two parts. One end it is the effort arm. This arm from fulcrum to the effort force is the effort arm, and the distance from fulcrum to the resistance of the weight is the resistance arm. So all these movements around our joint act as a fulcrum, and our muscles act as a effort, and whatever the body weight or any substances are lifting up, that act as a force. So most of the joint of our body are in a advantageous position, so that the less amount of force is required to lift up a heavy weight. That's the beauty of a lever arm. So with this picture, this is effort force, this is the resistance force, this is the effort arm, this is the resistance arm, and this is the fulcrum. So if you come to little bit discussion about the bit about the physics part, that whole in our body, most of the joints, they work on three types of liver. Basically, physical on physics there are three types of livers are there: first class liver, second class liver, third class liver. Most of the joints are working in our body in this liver system, right? So this is about the first class liver, where the fulcrum is at the center, and one end is the effort arm, effort and effort force, other end is the load or resistance force. So but this the position of the fulcrum changes from between the effort arm to the load arm. When the fulcrum is towards the effort force side, that means the resistance arm is longer and the effort arm is shorter. In other way, this picture, the resistance arm is shorter but the effort arm is longer. However, it may be any type of first class lever. The fulcrum is in between the effort force and the resistance force. However, the position of the fulcrum is variable depending on the different types of joint. So if you consider in our body, there are two major joints which works on the first class liver. So one is shoulder joint, another is hip joint. Shoulder joint, if you see that the center of the head of the humerus is the fulcrum, and the rotator cuff which works for the abduction mechanism is the effort arm, and the weight of the arm or for the forearm or the weight of the upper limb or associated with the weight carried by the upper limb is the resistance arm. So this is a first class lever where the fulcrum is lying between the force, effort force and the resistance. Similarly, for the hip joint also, this is the center of the hip joint which work like a fulcrum, and the body weight is the resistance. This is the on the along the S2 sacral vertebra where the body weight is falling, and the effort arm is the abductor force attaching from iliac blade to the greater trochanter, and this is the direction of the force. So if you look to this picture, this is the effort arm, this is the resistance arm, and this is the effort arm. So our aim is always towards to reduce the effort arm, to increase the reduce the resistance arm and to increase the effort arm. So this is another case example of the this first class liver in case of hip. So more closer to the hip joint center towards the midline, better is the mechanical advantage for the hip joint. Now, coming to second class liver, as I said, second class in a second class liver, the fulcrum is at one end, and the effort force and resistance force are on the same direction at different places, right? So in this picture, if you look here, that in this second class liver, this is the effort arm, this is the effort force and this fulcrum. That means the effort arm is longer than the resistance arm. This is the resistance force. So if you measure this distance and this distance, this effort arm is longer than the resistance arm. So in this case, since the effort arm is longer, so less amount of force is required, less amount of muscle power is required to get a movement or to lift up the body part or lift up the weight. So since the effort arm is longer, it needs a less force to get a desired momentum. That's why it is called a power lever. With a small force, it can lift up a heavy weight. That's why it is called a power lever. And the best example of the power lever is foot. How it works? How it works in a foot, how it works like a power lever. Just imagine we have a femur, you have a tibia, such a big long bones, but still in comparison to that, foot is a very small part of the body, but still it can propel the whole body weight. It can propel the whole body weight. If you look to this picture, this is schematic diagram. This is a tarsometatarsal joint, and where the fulcrum lies, and this is the body weight which, because the center of gravity falls under to the ankle, so this is the body weight. Maybe it passed through the midfoot, and this is the whole effort arm by the gastrosoleus muscle. So such a big effort arm in comparison to small resistance arm. That's why this is a power lever, because the resistance arm is lesser than the effort arm. So this is a power lever. The whole body weight is transmitted forward propelled by this foot, and this is the power is generated by the gastrocolius, and it is assisted by the plantar fascia. So since the foot is a small structure which propels the whole body weight, that's why it is a power lever. So this is a second class lever. Then coming to third class liver is a disadvantageous condition where if you sit here, that the effort arm, the resistance arm is longer than the effort arm, right? So this is the fulcrum, this is the effort, and this is the resistance. Think about a knee. Here the quadricep is attached to the tibial tuberosity. This is the quadricep tendon. So power, if this is the joint line is the fulcrum. So this is the only length of the effort arm. Whereas the whole body weight is the center of gravity is passing through the leg or through the foot. So this will be the resistance arm. So here the resistance arm is longer than the effort arm. That's why this is in a disadvantageous position, and body required more quadricep power to lift up the leg or to extend the knee. Same thing happened for the shoulder elbow joint also. The bicep tendon is attached to radial tuberosity, and this is the fulcrum of the elbow joint. So the distance, the effort arm is so small, whereas the resistance arm is so long. So this is a third class lever, but this is a speed multiplier. That the second class lever is a power multiplier. This is a speed multiplier, because with these small movements at the joint, the whole limb is moving with a larger torque. So this is a speed multiplier. So God has created this lever for the different purpose. We need a speed multiplier because for the upper arm and leg which requires more amount of motion, that's why they are coming under third class lever. Where we need more power propulsion for the foot, that's a the power lever. So foot is a power lever, and leg, knee, and elbow are the speed levers. So paradox is that if there is a eccentric contraction while the limb is falling back, that time it can work like a second class lever. I don't want to confuse you, but just for the sake that shoulder, hip joint are first class lever, foot is a second class lever, but elbow and knee are the third class levers. Okay, so what is a mechanical advantage? As I said that most of the body joints are in a mechanical advantageous position, which by that the human body requires less amount of force to have a more motion or the more movement. So a joint is in a mechanical advantage stage when the effort arm is larger than the resistance arm. So if you look to this picture also, see that this is the effort arm and this is the resistance arm. So a big heavy load can be lifted up by a single person, just shifting the pivot towards close to the resistance. So if you put the fulcrum over here, person may require more, you may require more force to lift up the heavy weight. But if you shift the lever fulcrum towards the resistance, so the effort arm will be longer, and you will require less force to lift up this heavy weight. So this is in a mechanical advantageous position. So if you go for a mathematical calculation, if the effort arm into effort force is more than the resistance force in resistance arm, that create a torque, that create a motion. But when these two multiplier is same as this resistance, it will cause a balance suspension. But we need that this effort arm into effort force must be higher than resistance force and resistance arm. And if you look to this equation, if the effort arm is longer, you need a less amount of effort force. If the resistance force is more, then even a small resistance arm can also produces hindrance for motion around the elbow joint. So we always try to have a either larger effort or larger effort arm. However, larger effort arm is always better because you need a less amount of effort first to achieve a movement. Now, coming to that, even if the effort arm is same length, but still the direction of the force also decides the how much amount of torque, how amount of movement will achieved around this joint. So this is example when the force is falling vertical or perpendicular to the effort arm, that will give a highest range of motion. But with the same effort arm, if the force is not perpendicular in an oblique manner, it reduces the torque. If the effort arm is reduced and the force is falling in a oblique manner, not at a 90-degree, the torque is further reduced. So all these biomechanical changes happen in a human body during different motion around different joints of our body. So how it is correlated with in cerebral palsy? So we all know that the major disadvantage in a CP is the movement. This is basically a movement disorder. This movement happen to the upper limb or will happen to the lower limb. So since the movement, the locomotion, the primary concern for parents. So we'll discuss more about the liver arm dysfunctions in the lower limb. So abnormalities of these liver arms that's greatly interferes with the child's ability to walk because of multiple factors. One is poor selective motor control. They don't have control of movements of the isolated muscles. So they have a combined group of muscles action, or they don't have that synergy that the agonist is contracting and antagonist is relaxing. That is not happened in case of CP. So that's created disturbance in selective motor control, and sometimes both agonist and antagonist both contracts together. That also limits the motion around the joint. And in long run, they also develop muscle contracture. Again, that creates a liver arm dysfunction. Abnormalities of bony liver arms or fulcrum, that sometimes is very soft. The liver arm is not rigid enough, like a foot. In case of flexible flat foot, the foot is there, but it's not rigid enough to propel the body weight. So that time the liver arm is soft, so it is not rigid enough. Sometimes the problem in the fulcrum, it may be subluxation, maybe dislocation. So the fulcrum is defective. So the obviously the liver arm will be defective. The ground reaction force is neither, as I said in the last previous slide, that the ground reaction force is whether it's applying 90 degree to the your effort arm or resistance arm or in oblique manner, that also decides the amount of movements possible around the joint. So optimal treatment of liver arm significantly improves if the quality of a movement in children is with CP. So the ultimate aim with the surgery, with the therapy, with the bracing is to optimize the liver arm to get appropriate movements around the joint in case of cerebral palsy. So, what are the different types of liver arm dysfunctions seen in case of cerebral palsy? So, the major problem we face in CP may be because of a shortening of the liver, because like in midfoot break, or there is a contracture around the joint. So, liver arm will be shortened. That's one possibility. Second, loss of liver rigidity. The liver is there, length is there, but it is flexible. Then third is malrotation. Because of rotation deformity of the limbs, the livers will not act appropriately. The liver arm one component is effort force. If the muscles are not in optimum direction, the optimum force cannot be generated. So that malrotation giving rise to a poor momentum around the joint. Then loss of a stable fulcrum, that is in the form of subluxation or dislocation, that can give rise to a liver arm dysfunction. So common liver arm dysfunction in CP are prominent are those are short liver arms in case of coxa valga. That's a C in case of hip joint where the neck shaft angle is increased. Then flexible liver arm is seen in case of pes valgus. In a midfoot break, there will be flexible liver arm. Third dysfunction is the malrotated liver arm, either internal rotation of the hip or external rotation of leg or external rotation of foot. These can also give rise to liver arm dysfunction. Abnormal pivot or action point, as I said, there is associated hip subluxation or dislocation that can give rise to also liver and dysfunction. Positional liver and dysfunction, especially in case of crouch because of position defect at the foot and ankle that affect proximally to the knee joint and hip joint, that are secondarily affected primary to the foot and ankle. So these all are the major liver and dysfunction seen in case of cerebral palsy. Let us discuss one by one. So the effect of liver and disorder, what will the impact? Change the line of muscle action, line of gravity and ground reaction force, resulting abnormal internal and external torsion of joint. So that happened around the hip joint, that happened around the knee joint, around the ankle joint. Inadequate transfer of forces and torques arising from the ground reaction force, change in the mechanical advantage of the body. Let us see what happened in different positions. The first problem will go from proximal to distal, that's the hip. What liver arm disorders happen in the hip? The major the problems occur as a liver arm disorder in CP child is the hip problem, especially in case of GMFS 4 and GMFS 5 non-ambulatory children. So what is its importance? Why should discuss regarding this? For a normal child who burn, they burn with coxa valga. Around neck shaft angle is around 150 degree. But with the influence of abductors force and walking, this gradually decreases to a normal adult range of around 115 degree to 120 degree by 8 years age. Right? In some diplegic, the degree of coxa valga can be as severe as 150 degree to 160 degree, leading to subluxation or dislocation of hip joint. So why these things happened? Why in the CP children this coxa valga happen? So as I said, the child born with a coxa valga, gradually that remodeled to a mature neck shaft angle of 120 degree in a ambulatory child. Either is each time the child stand, each time the child walk, when they started standing and walking, that head, the hip, when the child stand, when the hip is extended, once hip is extended, the head is coming in contact frequently with the ligament of Bigelow. You know all that ligament of Bigelow is the anterior ligament of the hip joint, which stabilize the hip joint in case, even in case of paralysis of the hip extensors, one can stabilize the hip by doing hip extension. So when the child started standing or kneeling, the hip is stabilized against the ligament of Bigelow, and the each time the head is in contact with the ligament of Bigelow, that gives a stimulus that reduces the anteversion gradually, and also the action of the this spastic iliopsoas and the delayed weight bearing spastic adductors or hamstrings, all these leads to develop of a coxa valga. So these corrections happen if the child started walking in the early stages. The late walkers, they develop coxa valga. So what happened to the hip joint? Why should we discuss about the coxa valga? What's happened to the hip joint if there will be coxa valga? Let us take example of this picture. This is a normal hip joint with 125 degree of neck shaft angle, and this is a coxa valga patient. So if you look, and this is the wet line passes through the S2 or S5 vertebra, right? So in a normal hip, you look to this picture. So this is almost balanced. This is the resistance arm, this is the effort arm by the hip abductor group of muscles. So this is almost balanced, and the hip center is over the center of the head of the femur. But when coxa valga occurs, that means neck shaft angle increases, head migrates towards laterally. So what will happen? That this resistance arm became longer than the effort arm. So when the effort arm is shorter, the more amount of force will be required to keep the pelvis in balance position. You all know that in case of abductor deficiency, there will be Trendelenburg gait. This abductor deficiency can be weakness of abductors, can be a fulcrum deficiency, can be fracture neck femur. But here there is no fracture neck femur. Here thing is that there will be abnormal load over the abductors because the effort arm is reduced. To keep the hip in balance position, the abductor has to contract more and more. So patient will have tremendous load over the hip joint, giving rise to early onset of osteoarthritis hip joint. There will be erosion of the cartilage. Patient will have pain around the hip joint, and there will be possibility of subluxation and dislocation of the hip as the hip goes more posteriorly and more upward by the action of this abductor. So patient will lurch, and the more amount of effort force will be to be generated by the hip abductors to maintain the hip joint. So question arises, then if the coxavara, what happened? Yes, in coxavara also same thing. In coxavara, this length from tip of the trochanter to the the abductor muscle length will decrease, and muscle will be in a disadvantaged position. Here the effort arm is decreased, that creating excessive load of the hip abductors, and hip abductor fatigue occurs, pain occurs, and again patient starts limping. So this is the disadvantage of the coxavara in case of CP. The next part is that's the liver arm, that's the short liver arm that I just now discussed here. Because of short liver arm, there will be excessive load over this abductor group of muscles. The abductor cannot meet the demand of the increased hip abduction force to, and so that the child will start swaying, right? So this is about how this is a normal hip. This is a normal hip where this is the this effector arm, and when there will be coxa valga, the effector arm will reduce. So the load over the abductor will increase, and patient starts limping or lurching. So this is about because of the short liver arm. Then next component is the excessive antiversion. We all know that excessive antiversion is a major problem in case of CP, for which the CP child walk with the internal rotation of the thigh and with the overall internal rotation of the leg. So in a newborn, the baby born with excessive the this femoral neck angle, and there will be the antiversion is around 30 degree or 31 degree, and that reaches 15 degree by 16 years. So normal antiversion is 15 degrees reached by age of 16 years, but that is possible when the child started standing and walking. As I said, that when the potential stimulus from the ligament of Bigelow, which try to remodel the neck shaft angle, bringing to a normal neck shaft angle around the age of 16 years. So when the neck shaft angle is increased, if you see this picture, when the neck shaft angle is increased, the head is directed more anteriorly. So when the head is directed more anteriorly, the greater trochanter became in a posterior position. So when the greater trochanter is posterior position, the hip abductors are in a disadvantaged position. So instead of abductors in this position, this is the effort arm. So the abductor will be now posteriorly displaced. The effort arm will be decreased. So this also creates a liver arm deficiency. So coxa valga, excessive anteversion are the two major liver arm dysfunctions in case of spastic cerebral palsy in a non-ambulatory child, that is in GMFCS 4 and 5. This create a malrotated liver. As I said, when the anteversion is there, the head has to go to the acetabulum. The to entering the bringing the head back to the acetabulum, the limb has to be internally rotated. The femur will be internally rotated to maintain the center of gravity, to maintain the limb progression. The gradually the leg will be externally rotated. When the externally rotated, the foot will be externally rotated, and there will be valgus. So one problem at the hip joint which lead excessive anteversion, which causes this femoral internal torsion or internal rotation of the femur, that again for the balance that create external rotation of the leg and external rotation of foot. So one problem at the hip joint manifested at the foot level. So this is how a chain of events occurs because of a malfunction liver arm around the hip joint, for which we have to give focus over the hip joint, especially in a non-ambulatory child, so that this subluxation and dislocation can be prevented and liver arm can be corrected. So as I said that when there will be excessive load by the abductor muscle, and there will be excessive anteversion, and there will be spasticity of the adductors also, iliopsoas and adductors, that creates a subluxation force, and the head gradually subluxate out. So if the migration percentage is more than 30 degree, there will be instability that causes subluxation. When the migration for the percentage is more than 50 percentage, then that causes dislocation. How the migration percentage is calculated? You just draw a Perkins line on the lateral edge of the sternum, and a Hilgener's line along the tridentine cartilage. Measure the diameter of the head and see how much of head is out of the Perkins line. So this exclusion of the head out of the sternum divided by the total diameter of the head into 100 is the migration percentage, right? So if the migration percentage is more than 30 degree, you have to be very cautious. You have to take adequate precaution to prevent further subluxation to a frank dislocation. That is the reason why we should go for a hip scanning for all children with cerebral palsy of GMSS 4 and 5. So this subluxation is possible because of muscular imbalance between adductors and abductors, persistent femoral anteversion, persistent coxa valga, delayed weight bearing, which again delayed the remodeling of the anteversion, and abnormal muscle forces. As I said, the trochanter is displaced posteriorly and abductors are in a disadvantageous position. So all these factors giving rise to subluxation and dislocation of the hip joint. So we can see it here that hip is started subluxating this side. This is just starting. This is almost the more than 30% hip subluxation there. There is almost neck shaft angle is 160 or 170 degree. If you sit here, almost straight head as if the neck is over the shaft. So don't forget to take X-ray for CP children who are non-ambulatory. So in these CP children, strong hip flexors and adductors against the weak hip extensors and abductors, or a abductor in a disadvantaged position. So that gives rise to the more action of the hip flexors and adductors that favor subluxation. The femoral head center dislocates distally and to the left trochanter. There is changing the direction of the magnitude of force that causing the serious liver dysfunction. As I said earlier, hip dislocation in a posterior and superior direction. Posterior, why? Because the iliopsoas is always pull the hip to the flexion. The head goes towards the posterior direction, and the direction of the hip abductors are also in disadvantage position. Instead of abduction that pull the head more proximally, and in a long run, each time the head hit to the acetabular, that creates gradually secondary acetabular dysplasia. That means flattening of the acetabular head. But how to difference between a hip subluxation in a normal child with a DDS and CP is that if you see that CP child started subluxation at 2 years age, the acetabular index will be less than 30. That means there will be a roof will be there. But this same child, if the subluxation continues and non-weight bearing continues, the head hit to the superior surface of the roof of the sternum, that became flat. So at the age of 6 or 7 years, in a subluxated hip, you will get a frank acetabular dysplasia. Like it mimics like a hip DDH, or developmental dysplasia of hip. But the difference between a DDH and a CP with the subluxation is that in early stages you will get a adequate roof of the acetabular in case of CP, which is not seen in case of developmental dysplasia of hip joint. We have today one case with the CP with bilateral subluxation in the hip. Today itself only we took the child to the OT, see under examination, under anesthesia, see under CR whether it is subluxing with the dislocating. So and we saw that we were confused with the DDS, but when we examined the child under CR inside the OT, we saw that the head is very beautifully going inside the acetabular. In case of DDS at the age of 4 years, 5, it's very difficult to bring the head to the acetabular because the acetabular is filled up with the pulvinar tissue. But in the today the child was having CP. We were confusing with the DDS, maybe associated with the DDS. But when we examined under anesthesia, we saw that head was beautifully going inside the acetabulum. That was showing, giving idea, no, this is not a case of DDS. So the difference of the treatment pattern was different from a DDS to a dislocation hip because of CP. Simple way you can go for a varus osteotomy to bring the head back into the acetabulum, which is not possible in case of DDS. So a varus osteotomy can be done by any physiatrist, very simple procedure for doing. So this fulcrum disorder can be managed at our level if you can tackle it in early stage. So there, if you compare the hip subluxation with respect to the GMFC level, the straight line, the relation is almost a straight line. Okay, so as the GMFC level increases, the chances of subluxation gradually or dislocation gradually increases from 15% in a GMFS 2 to 90% in case of GMFS 5. So see, just imagine the extent of prevalence of subluxation dislocation hip in case of CP, especially in GMFS 5. So how do you manage these type of cases? Depend upon that how early you have identified the hip subluxation. Last hour, this PMR refreshers course, Dr. Anand Verma was presenting that this there is an app for the evaluating the scanning of the hip joint, hip scan. From that, you can early stages you can assess the subluxation dislocation. In the early stages, if you can detect that if the hip is subluxating, it is 20-25% has reached to the and the migration percentage. In early stages, you can simple go for adductor tenotomy, go for only adductor longus and brevis, not to the magnus, to get a appreciable amount of abduction achievement, say around 60 degree of abduction need to be achieved, so that you will prevent a future subluxation. But in case of a GMFCS level 5, the non-ambulatory child, to prevent further contracture of the adduction contracture, we can go for obturator neurectomy, especially anterior division, in case of non-ambulatory child. In case of ambulatory child, presented with a more than 40 degree of subluxation or the more than 40% of migration percentage, then we have to go for varus derotation osteotomy, and a very severe cases may be required a acetabular reconstruction. And adolescent patient or adult patient having hip subluxation dislocation, probably the reconstruction is not possible. Those present at very late age, 15 year 20-year age, maybe that time if the hip is painful, then we'll have to go for salvage procedure like excision of the head of the femur. So that is reserved for non-ambulatory children with complete dislocation of the head having a painful hip with problems in perineal hygiene. That's reserved for this hip salvage procedure. In doing it, very often we see in case of CP, almost 64% of diplegic CP, they have intowing gait, and that intowing gait is because of excessive anteversion or tightness of the adductors and medial hamstrings. The whether it is a hamstring or because of excessive anteversion, you can check anteversion test. The simplest test is crack test to see that how much of anteversion is there. If the severe anteversion is there, then we may require to correct the anteversion by going for a derotational osteotomy. But if the anteversion is not that much severe, but still patient is walking with a entowing gait or internal rotation of the limb, then we have to check whether this is because of adductor tightness or because of medial hamstring tightness. By releasing these two structures by fractional lengthening, we can correct the internal tibial torsion. And sometimes it is so severe in case of diplegic that maybe we require bony correction. If the deformity is more severe at the femur, we can go for subtrochanter osteotomy. If the femur is not that much of internal torsion is not there, but there is an internal torsion at the tibial level, we can go for a supramalleolar osteotomy. So these are the procedures which are done for a internal rotation. Right. So whatever therapy you follow, whatever orthosis you give, you cannot allow the child to walk. Even with the orthosis, each time the foot will go to internal rotation, you will be helpless. The child cannot walk each time the foot is hitting with each other, and child cannot walk. That's the only solution to help you is by surgical means, by lengthening the medial hamstrings, or if the deformity is very severe, you can go for derotation osteotomy. So these are very simple techniques to know. because there is no other way to correcting the internal torsion, and your orthosis is not going to help these children. Now, coming to outgoing gait, you will get sometimes foot will be outgoing as a compensated mechanism of the internal rotation of the hip joint, sometimes compensated by external rotation of the tibia. So when the tibia get external rotated, the foot also get external rotated. So when the foot get external rotated, there will be valgus of the associated valgus of the foot joint. So this external tibial torsion is associated with pes valgus. You know, pes valgus is a flexible foot. It is not rigid foot. To foot become rigid, there must be foot must be supinated. But unfortunately, this tibial torsion associated with the foot external rotation is a pronated foot. So how it affects the lever arm? Let's see that this is a normal foot. If you see that in the subsequent, I will show you that the tarsometatarsal joint is the fulcrum for the foot propulsion. So this is the length of the lever arm for the gastrosoleus muscle to work. So when the foot get externally rotated, just see that the now this is the fulcrum, and if you just draw a perpendicular line, this will the length of the lever arm. So certainly this lever arm is shortened in comparison to the normal foot when the foot get externally rotated. This is how that the lever arm deficiency disorders occurs in case of foot when the foot is externally rotated, when the foot is pronated. So that affect the knee. So knee is a sufferer, suffering because of the foot abnormality or at the hip abnormality. Basically, the knee suffered because of the this loss of this plantar flexion knee extension couple. We all know when the foot is a plantar flex in a rigid supinated foot, the center of gravity fall under to the knee joint during the propulsion. Even if the quadricep is weak, still then knee will remain in extension. That's the plantar flexion knee extension couple. This is very essential how the foot controls the knee joint. If the foot can be maintained as a rigid lever and which maintain the center of gravity and to the knee buckle will not be happen, and the patient will not go to crouch. And in this process, the soleus has a major role where the soleus will pull the upper tibia back, so the center of gravity will be front of the knee. So we'll discuss in the subsequent slides. When this foot rotation, the femoral anteversion with a compensatory external rotations are combined, that's called a malignant liver arm dysfunction. Very soon the patient will go to crouch and very difficult to manage them. So we have to differentiate the separate from this knee to hip to the foot, so that the both will not be combined. It will not land with a malignant liver arm dysfunction. So as I said, food is the major issue where the problems that lead to the knee problem and hip problem. So each time the foot will try to keep the your center of gravity anterior to the knee, posterior to the hip, so that hip remain extended, knee remain extended, and body weight propulsion is possible by the strong effect of this gastrosoleus muscle. So we have already discussed that this is a second class lever. Here the load is in the middle of the foot and the effort is the farthest from the fulcrum. This is the fulcrum. The farthest from making the second class lever most mechanically advantageous position. That is possible by the strong action of the gastrosoleus muscle. Both the muscles has effectively work here. The soleus draw the this tibia back, and at the same time also the gastrocnemius muscle has a synergistic effect with the soleus to propulse the body weight on a rigid foot. So this tricep surae or tricep muscle or the gastrocnemius muscle that act as a effort force, and the line of gravity or the resistance force will be fall on the midfoot. So this is the effort arm, this is the resistance arm. So effort arm is larger, then the less amount of force is required to propulse the body weight. So what dysfunctions occurs in case of foot and ankle? This is a very important slide. Please go through this. A normal foot locomotion in a stand space, when the foot passes from heel strike to toe up, it passes through three levers. It passes through three levers. So the first stage is the when the heel strike occurs. The first lever works where there will be smooth the plantar flexion of the foot that touches the ground smoothly because of the eccentric contraction of the dorsiflexor of the ankle that gradually drop the foot down, so that the center of gravity or a body load will smoothly transit from heel strike to the antepath to the midfoot level. Right? This is the first lever. This is the first lever from heel strike to mid stance level. That's the foot flat level. Right? That's the action of the pretibial group of muscles. That's in the first rocker. The second rocker occurs from foot flat towards the toe upstairs. That is transition from foot flat to heel up, towards heel up, so that this the center of gravity will come towards the midfoot. That's the second rocker. Third rocker is the effective rocker on which body weight is transmitted. If you see this picture, third rocker is the effective rocker where the body weight is transmitted more distally towards the fulcrum, so that the resistance arm becomes short and the effective arm became longer. That's the third rocker where really the body is transmitted effectively, and the body weight, the line of gravity will come anterior to the knee and posterior to the hip, thereby stabilizing the hip and stabilizing the knee. So this smooth process of first rocker, second rocker, third rocker helps in propulsion of the body weight throughout the stance phase of the gait cycle. So these three rockers are not usually happen in case of cerebral palsy, where there will be inefficient action of the soleus muscle and inefficient transition of the first rocker to second rocker to third rocker. Right? So what happened in the next stage? This is how the whole body weight is transmitted by the gastrocnemius muscle and the plantar fascia assistance. So this picture I have already described you how it works. The when the heel strike goes to midfoot, second rocker, transmission of the body weight from center of the ankle towards the midfoot. Here this is the soleus where it works. The soleus pull the tibia posteriorly so that the center of gravity remain anterior to the knee joint. On failure of the soleus function, the proximal tibia go anteriorly and the center of gravity will go posteriorly, and this there will be flexion of the knee joint. When the knees get flexed, then secondary hip will get flexed. So this is how I have already also this part discussed. When the foot get externally rotated, a valgus foot, how the lever arm decreases. This is the function of the soleus. The soleus work in a close kinetic foot motion when the foot is on the ground. So the foot cannot go for plantar flexion because foot is on the ground. So what will happen? That the whole force will be transmitted proximal to the proximal tibia, which brings the tibia back, so that the center of gravity will fall in front of. But in case of soleal deficiency, what will happen? See in this picture. In case of soleal deficiency, the tibia will fall anteriorly in the second rocker. This is not when the rocker moves anteriorly, the tibia moves anteriorly, dorsiflex over the ankle joint. That time soleus is supposed to prevent further progression of the tibia anteriorly or rolling the tibia. But failure of soleus, tibia roll more anteriorly and the center of gravity falls posterior to the knee joint, causing knee flexion. So this is the whole mechanism, soleal weakness leading to crouch. So this lever arm problem in CP in around foot is the excessive pronation. As you all know, pronated foot is soft foot. In a normal child with a flexible flat foot or CP with a pronated foot, all pronated foots are flexible foot. They are all flexible, flexible river. But in a supinated foot is a rigid liver. Supinated foot is in case of hemiplegic CP with a heel in inverted position, a varus position. As you all know, varus foot or varus heel locks the subtalar joint, creating the foot rigid. That's why in case of hemiplegia, the foot is in a supinated position, foot is rigid, and the in a rigid foot when propulsion occurs, that causes knee hyperextension. If you see in case of hemiplegic child with a supinated equinovarus foot or supinated foot equinus position, they walk with a hyperextended knee. But the reverse occurs in case of diplegic CP, where the foot is supple, foot is pronated. So the second rocker failed here and the tibia goes anterally, causing crouch. So this is the midfoot break, which brings the tibia more distally and the fulcrum more distally. So that creates a false fulcrum at the midfoot level. This picture I have already explained you how the excessive pronation reduces the extensor lever arm of the foot. So, in a diplegic CP, sustained gastrostomal spasticity is in a valgoid foot results a break at the midfoot. You can see it here there is a midfoot break. The effort on the foot lever is decreased as I said in the previous picture. The plantar flexion movement is insufficient to extend the knee, that is failure of the plantar flexion knee extension couple. The movement genetic capacity is the key to the good musculoskeletal function, which is lacking here. So this work in a chain fashion. The failure of the liver function, the foot joint affect the knee and affect the hip, giving a full blown crouch, which is very difficult to manage. You can see it here that in case of crouch, when the foot goes more towards the midfoot, the midfoot break it here. The distance, the distance from the fulcrum or the tarsometatarsal joint to the line of force will be this is the distance will be decreased. This will be another fulcrum here. So the effort force will be here. Instead of this will work like a joint. So the effort arm will be decreased because of midfoot. So that creates this lever arm disorder in case of foot. So to manage that, the foot has to be rigid enough for propulsion of body weight. You have facility of surgery, fine. You can go for subtalar arthrodesis or talonavicular arthrodesis to make the foot rigid. If that facility is not there, you can go for AFO with a supinated foot, AFO with a metal arch. Foot remains supinated in case of with AFO. That helps to make the foot rigid, and that will prevent the center of gravity to fall back to the back of the knee, and knee can be controlled with the help of AFO. So my take home message is children with CP exhibits a variety of liver arm disorders with characteristic changes in the gait pattern. Identify not only the muscle strength deficiency but also liver. Very often we only check about the muscle power. That's not good enough. Even a good abductor power in a hip, because of the increased anteversion, the GT rotate posteriorly. The muscle power is normal, but still it is not working effectively. It is not working in its own line of course of action. That's why the muscle power diminishes. Understanding of appropriate liver arm disorder is important for planning of all gait improvement procedure in CP. Early identification can slow down the progression of the liver dysfunction. If you control the foot from the very beginning, probably you can control the deformity at the knee joint and deformity at the hip joint. So liver arm dysfunction that interferes the function should be managed regardless of the age. So as early as you detect the dysfunction, control that, then probably you will subsequently prevent further disorders more proximally. Thank you. So this is basically a nutshell about that what are the possible liver arm dysfunctions possible. The major problem is the hip joint, and next problem is the foot and ankle.
Sir, there are few questions in the chat box.
You can ask the questions. Just read out the question.
Yes, sir. Uh, are there only surgical correction needed for intoing gait or any other way for correcting intoing gait, sir?
No, as I said that you have to see by Craig stress how much of the anteversion angle. The anteversion angle is within appreciable level. Then next is the hamstring group of muscles or hip flexors. If the hamstring spasticity is more, then and presently having severe entering gait, yes, you can go for surgical correction by going for a fractional lengthening of hamstring. But if the POP angle is less, say around 50 degree or 60 degree, yes, you can go for buttocks also. Basically, this is the spasticity of the hamstrings which is giving rise to medial hamstrings, which is giving rise to a entering gait. If the this the antiperson is not that severe, so in that situation you can go for relaxing the hamstring with the help of injection of botulinum toxin to the medial hamstring group of muscles.
Okay, sir. Next question: how to remember concentric or eccentric contraction of muscles in gait cycle?
Which muscle concentric eccentric?
Uh, like in the gait cycle, how to remember which muscle is going concentric and which muscle is going eccentric contraction?
It depends upon the muscle. Like suppose these are predefined muscle contractions happen in a normal locomotion. Like we just discussed now fast rocker. When patient is on hill strike stage, the foot to tibia is 90-degree angle. So foot has to be plantar flex gradually. So that time the dorsiflexor must work. If the dorsiflexor will not work, the foot will there will be foot slap. Like in case of some form of like initial stage of flat, the foot drop like type of gait, you'll have a foot flat. So that time the muscle will gradually contract and gradually relax, and that will give a smooth transition of foot to the ground. Same thing happened for for example, you are gradually flexing a knee on the side of a couch. So if you relax the quadricep, the leg will drop down immediately. But if you want to gradually bend the knee, your quadricep has to be contract, that eccentrical contract. In eccentrical contraction, the length is not certain, but the tone is increased.
Yes. Sir,
In
how
normal concentric contraction, the tone increases, the muscle shorten. But in eccentric contraction, the tone increases, the muscle not shorten, rather it is lengthened.
Sir, next question: how will we achieve supination in a AFO?
Simple, if you give some a medial arch support or medial elevation on the medial side, if you are doing with a polypropylene type of AFO, solid AFO, put the elevate the mold your foot in mild supine position while you take a mold for that or take a cast for the preparing your AFO, prepare the AFO with a little bit supinated position with support on the medial side. So that will some extent helps in stabilizing the subtalar joint.
Sir, will tone reducing orthosis can help in these conditions like planovalgus? Tone reducing orthosis in CP.
Yes, it can help. It can help.
And
You
in
have
plan,
to just add some, you need a rigid foot, whatever it may be. This tone inhibiting is just extension of a normal or the AFO to the tip of the great toe to keep the great toe extended position. But this normal work like a solid AFO. Nothing harm in that.
next question: in planovalgus, how AFO will help?
No, basically you need to foot to a rigid, right? So for a normal plano valgoid foot, if you give only a arch support, still the foot is not rigid enough. The quadricep will not contract, the gastrocep will not work in an effective way. If you give a AFO, basically this is a just to support the second rocker of the foot, so that if you will have a strap at the proximal tibia, so that will the work some it will help in the just work the function of a soleus muscle, right? If the AFO is not be there, you just simply manage with a medial arch support with a foot. Nothing is there to restrict the tibia to bring the tibia posteriorly. So if you give a AFO, the strap helps to keep the tibia drawing going more anteriorly, so that the CG will fall posteriorly. I hope it is clear. If the plantar valgoid foot, you are only correcting the foot, there is no restraint to the proximal tibia. That's the replacing the work of soleus. But if you give a AFO, your proximal strap will attach to the proximal tibia. That also helps in restraining tibia go forward. That prevent the excessive second rocker in a foot. That's how it helps.
Okay. Sir, can you please explain this foot rocker slide one more time?
One more time. Yes, there are three rockers of the foot in a foot. When we the first stage, initial stage of the your stance is the heel strike. So in during heel strike, you need to that the foot must be smoothly come to the ground with a smooth motion. So that smooth motion is possible by the help of the pre-tibial group of muscles that controlly eccentrically contract and control motion the foot comes to the ground. The same thing for our SAS foot also. SAS foot, the heel rocker is given makes up because for a smooth transition from heel strike to foot flat. Right? That's the first rocker. Second rocker in the foot flat stage when the further dorsiflexion occurs by rolling the tibia over the ankle joint because it's a closed kinetic chain. Foot is on the ground. Foot cannot go for plantar flexion. So here the tibia rolls over the ankle joint, right? That's the second rocker. So that second rod excessive rollover is prevented by the soleus because foot is on the ground. Then third rocker is from foot flat to toe up stage. Okay, so that's again smooth transition of the fulcrum towards the metatarsophalangeal joint so that the gastrosoleus will act effectively and the effector arm of the foot will be increased so that less amount of force will be required by the gastrosoleus muscle for propulsion of the body weight. So this third rocker is important for the effective propulsion of the body weight. That's how the three rockers work in a stance phase of the gait cycle.
Sir, no more new questions, sir.
So if there is no more question in the chat box, thank you very much. We can conclude the session. Thank you all participants for joining this webinar. This was a very uncommon talk, but often helpful in your clinical decision making during your management of cerebral palsy. Unless you are not aware about the core things, what is happening, why this deformity is happening, why this gait abnormality is happening, unless you don't know the core part, it's difficult to take a decision that what thing to be done to correct in the deformity or the improving the gait. Basically, nowadays you cannot say it is a deformity correction. We call it is a gait improvement surgery or gait improvement management. Our objective is to improve the gait so that less amount of force is required for normal propulsion. That's the whole theme of this correction of liver arm disorder. Thank you everybody for joining us, and thank you the our All India Indian Association of Physical Medicine Rehabilitation, especially the PR team, providing us this Zoom platform for this continuous this academic event. Next time we'll come with another interesting talk by the Dr. I'm forgetting his name. So another talk in the second week of the Anant Kumar. He's committed. He's promised me to take the next class by Dr. Anant Kumar. Definitely, he will have a good discussion from his experience how he's doing managing his cases alone. That will be good discussion. Hopefully, all will join in the next webinar. Thank you all. Thank you for joining us. Good night.